I would like to call upon our next speaker, Dr. 𝐕𝐢𝐃𝐑𝐂.
It is my pleasure to present our experience of 500 kidney pair donation transplantation at Kidney Institute, Ahmedabad. As per GODT data, worldwide, less than 10% of patients have access to organ transplantation. 2 to 7 million people die every year worldwide due to inability to pay either for dialysis or transplant. India is number 3 in the world for absolute number of organ transplants, mainly because of living donation. 80 to 85% transplants are from living donation. 15 to 20% transplants are from deceased donation, which is more active in South and West India. 80% transplants are in private sector hospital and 20% transplants are in public sector hospital. This is the GODT data submitted by NOTO to the GODT registry showing organ-wise distribution of transplants. Red column indicate deceased donation, green column indicate living donation, and blue column indicate total number of kidney transplants. This is the data from 2013 to 2022. I will present our experience of swab transplant at Kidney Institute, Ahmedabad, the largest public sector transplant hospital in India, and this was inaugurated by Honorable Prime Minister Shri Narendra Modi ji. We have 1250 beds total for multi-organ transplantation. In addition to these 1250 beds, we have additional 1000 beds for maintenance dialysis in 270 satellite units in urban, district, tribal area, because transplant is received only by less than 10% of patients. So other option is the maintenance dialysis. This is the year-wise distribution of kidney transplant at our single center, IKDRC ITS Ahmedabad, from 2000 to September 2023. The red column indicate deceased donor kidney transplant, green column indicate living donor kidney transplant, and blue column indicate total number of kidney transplant in the respective year. So by and large, we now perform around 400 kidney transplant, and there was dip because of COVID-19 pandemic, and after COVID, our deceased donation number increases significantly. Coming to paired kidney exchange, 1/3 of the living donors, they are rejected either because of ABO blood group is not matching or they are having sensitization. This is classic example of conventional two-way kidney exchange, where two incompatible pairs exchange kidney with each other to get ABO compatible transplant. 90% of swab transplants in India are two-way exchange because the logistics are very simple for taking legal permission and to carry out simultaneous transplant surgery. This is year-wise progress of swab transplant at our single center over last 23 years. The first swab transplant at Kidney Institute Ahmedabad was performed in year 2000. From 2000 to 2010, the program was managed by transplant coordinator, and there was hardly 50 swab transplant over the 10 years. In 2011, I was made in charge of the swab transplant program at our institute. Thereafter, there is a substantial growth and progress in number of swab transplants, and in last 12 years we completed additional 450 swab transplants. This is the percentage of swab transplants, that is percentage of living donor kidney transplant. So again, from 2000 to 2010, the swab contributed to 2 to 3% of total living donor kidney transplant. And in year 2015, the swab contributed to 25% of living donor kidney transplant at our single center. During the COVID pandemic, the number decreased to around 10%, and again now we increased to near to 20% in the year 2023. So swab contributed to more than 15% of living donor kidney transplant on an average in our single center. The upper panel is showing number and lower panel is showing the percentage. What were the allocation rules? We did ABO compatible swab only. Use short chain over the long chain to avoid logistic problems like legal permission and simultaneous transplant surgery. We minimize age difference between the donor. From the patient and donor perspective, this parameter is most important. We allow all patients and donor to meet each other before we finalize their pairs. We allow them to share medical reports with each other. They can take opinion of their family physician or any other transplant team members from any other city. So that is known as non-anonymous allocation. So first question when donors meet each other is that what is age of my donor? So they anticipate that donor age difference should be minimized. Over the last 5 years, we are using the software provided by Alliance for Pair Donation. Dr. Michael Ridge is sitting here. And of course, we are also getting guidance from him all the time as and when required. This software is very user friendly, and this avoid all the problems of manual allocation. Because one of the problem in manual allocation is that fear of unequal outcome. In case of unequal outcome, the patients and donor can blame the transplant team member for the manual allocation. That problem is overcome in the software allocation. And what are the key features of our single center swab program? Awareness and counseling. In 2011 onwards, we counsel all patients about the swab transplant, ABO incompatible transplant, pros and cons of dialysis, hemodialysis, peritoneal dialysis, so that patient can take informed decision which is the best modality for him. And of course, the swab is the cost-effective way having better long-term outcome. Then we started a dedicated single center registry, because every year we perform around 500 living donor kidney transplant. So 1/3 of the donors are rejected. They are easily registered in our single center registry, and matching is offered to the patient and donor. Dedicated teamwork. So we have a dedicated transplant team which help the patients for taking legal permission, for getting finance support from the government. That is very important. Uniform evaluation and care of patient and donor. Standardization of HLA laboratory. We have inbuilt an advanced immunology lab which was initiated by founder of immunology like Professor Paul Terasaki. We have inbuilt all tests available. So robust immunological evaluation for all the pair with lymphocyte cross-match, flow cross-match, donor-specific antibody. This prevent unequal outcome because of immune injury. And we also explain each patient that despite doing all efforts, there could be unequal outcome in the patient. The chance is 6 to 8%, but this unequal outcome is because of patient related factor, not because of donor related factor. For example, patient is diabetic or heart disease and he can get infections early, immediately after transplant. This unequal outcome is because of patient related factor. So that is well explained to the patient. Non-anonymous allocation, exchange kidney of similar quality, and we try to do a simultaneous surgery, but in our centers out of 500, 71 swab transplants are done in a non-simultaneous way when we perform 3-way or longer chain. Out of 500 swab transplants, 71% were ABO incompatible, around 20% were sensitized patient, and around 10% of the patients they participated who were compatible pair, they participated to get advantage like better HLA matching or young donor age. So in case of spousal donor with age above 45 year, especially O group donor, we counsel them about the benefits of getting in swab transplant, and around 10% are transplanted in this way. From 2000 to 2012, over 12 years, we have performed only 2-way exchange. First 3-way exchange was performed in 2013, and we gradually increased chain length to 10 patients and 10 donor in year 2020 to increase transplant for difficult to match patients like O group patients and sensitized patients. So 75% were 2-way exchange, and 25% patients were 3-way, 4-way, 5-way, 6-way up to 10-way exchange. So we use long chain when we provide transplant for difficult to match patients. So the new centers should start with a simple process of 2-way exchange, and gradually they should increase the chain length from their own learning experience, how they were able to overcome logistics for legal permission, and large number of team is required to carry out simultaneous transplant surgery. Again, the compatible pair is game changer to increase transplant for O group patients. To increase transplant for difficult to match patients, we use swab with desensitization protocol. 50% of our pairs, they are from other parts of India, and they get free transplant under various schemes of central government. Under state government, we get rupees 10 lakh rupees for kidney transplant under Pradhan Mantri Jana Arogya Yojana Mukhyamantri Amrutam scheme. And 10 lakh is good amount for kidney transplant. Even any private hospital can do transplant in 10 lakh in India. Then we use a combination of swab with desensitization similar to the John Hopkins protocol. What should be the optimum chain length in kidney exchange? Optimum chain length is 3-way exchange. If we increase chain length, this will just increase the logistics, and there is a potential for chain collapse before actual transplant surgery. One of the major limitation of swab is transplant for O group patient and highly sensitized patients. So for the single center program, compatible pair is a game changer where we can easily increase match rate and success rate with the help of compatible pair. Other way to increase transplant for O group patient is a combination of KPD with ABO incompatible transplant. For example, the patient is having higher baseline ABO titer with their original family member. For example, the titer is above 5012. Many centers in India don't do ABO if baseline ABO titer is high. And if the ABO titer is less with the swab donor, this would decrease the cost of desensitization protocol and obviously the infectious complication. So this way is used in the Australian kidney exchange program to increase transplant for O group patients. 90% of the patients are not aware about the swab transplant. So to increase awareness, on occasion of World Kidney Day 2013, we have performed swab of 10 patients and 10 donors in single day. And these patients thereafter become advocate and education ambassador for the swab transplants. They did advocacy in their respective dialysis area. Over 10 years follow-up, because this study was done in 2013, the patient and graft survival is now 90%. That is very important. In 2015, we have reported increased living donor kidney transplant by 25%. And this is our world record of highest number of living donor kidney transplant in single center in 1 year, 77 KPD transplants. Who can donate in swab transplant? Only near related donor. That is parents, spouse, sibling and grandparents. Uncle and other near related donor, they can directly donate as in ABO transplant but not in the swab transplant. We have also done international swab transplant after appropriate permission from state government. This is one pair from Portugal and other pair from Rajasthan. At 8-year follow-up, both the patients having normal creatinine. We have done 4-way swab with desensitization, 4-way non-simultaneous swab to increase transplant for difficult to match patients. In 2018, we reported first single center 5-way non-simultaneous kidney exchange cycle. These 5 pairs were from 5 different states of India. Notably, all permission for swab transplant can be given by transplant hospital or district or state in which swab is proposed to be done as per 2014 amendment. There is no need to take permission from different states. For example, these 5 pairs were from 5 different states. So, Gujarat State Government Committee give permission for the swab transplant. Many other states, even today, when pairs are from different states, they send file for taking permissions for the other state. So I think this just increases the time required for taking this legal permission, and that is not necessary as per Transplant Human Organ Act 2014 amendment. We have also done 6-way swab transplant non-simultaneous surgery, and in 2019 also these 6 patients and 6 donors, they are from 6 different states of India. Permission is given by state level committee of government of Gujarat. There is no need to send file from 6 different states for taking the legal permission. In January 2020, we performed the longest chain of 10 patients and 10 donors. These 10 pairs were from 7 different states of India. And we performed non-simultaneous surgery because of limited surgical team in particular period. Non-simultaneous surgery was done after consent of the patients and donors. The patient survival, graft survival is 100%. So far, we have done 71 non-simultaneous transplants using 21 bridge donor with median wait time of just 2 days. Basically, these surgeries were done on consecutive days. Obviously, the gold standard is simultaneous transplant surgery. So, KPD is basically bureaucratically complex and medically simple. And desensitization protocol is medically complex and bureaucratically simple. But cost and infectious complications are common concern for desensitization protocol. Outcome of swab transplant is similar to any living donor kidney transplant program, and for ABO transplant for initial 1 year the outcome is inferior, although long-term outcome is similar. What is impact of donor recipient age difference? Age difference, our single center study shows that there is no impact of donor recipient age difference below 20 versus above 20. And UNOS data and Australian data also confirm that donor age does not matter in living donor kidney transplant in age group of 18 to 65 years. In swab transplant, despite poor HLA match, the outcome is similar to living related donation with better HLA match. This is a short-term analysis, and thymoglobulin induction, TAC, MMF and steroid-based immunosuppressive regimen could explain equal outcome in a short-term analysis, although long-term analysis is awaited. Indian Society of Organ Transplantation has published this guideline to provide solutions for common problem related to the swab transplant. Gujarat is the first state to approve living versus deceased donor list exchange. This is approved just in January 2020. Because of COVID pandemic, it is not a real transplants, but this is approved so far. So to conclude, KPD should be available at each transplant unit. We should start and expand starting from single center program to city-based program, then state program, national program, and thereafter the international program. So gradual expansion of kidney exchange is important rather than directly jumping to the national program, so that we can learn from our own experience. Future possibilities: combination of KPD with ABO incompatible transplant, multi-center program, liver versus kidney exchange, and list exchange. Our study provide evidence for expansion of single center living donor kidney transplant via KPD when national program do not exist. I would like to acknowledge mentorship of Dr. H.L. Trivedi, and all the transplant team for completing the 500 swab transplant in single center, that is largest number of swab transplant in single center in Asia. Thank you for your attention.
Do we have questions?
Thank you very much, sir, for your elaborate presentation. I'm Dr. Sailendra from Nepal, and we have also a transplant program in different centers in Kathmandu, and some centers have started doing these paired kidney exchange. So, but it's not just started. We are still in the infancy, so we still have a lot to learn from your experiences. I just have a small question, and that is, you said that you are not taking the extended family members as in your donor pool. So doesn't that limit your donor pool? And why are you not taking those
So
extended
this is
family
our
members?
Transplant Organ Act India, because at present this is restrictive. So we have to follow the Organ Act of India.
But if you are doing a live donor kidney transplant, you are taking the kidneys from the extended family members. Okay, so it's only for the KPD
Yeah.
program you are not
Yes,
taking.
yes, yes.
So is there any specific reason for that?
No, law doesn't allow in a, so if law does not allow, we have presented to the government that this should be expanded. For example, if uncle can participate in ABO, why not in SWAB? Because it is a cost effective. So probably time with time the law will change and we will able to expand the donor pool.
Thank you very much, sir. We still have a lot to learn from you.
Yes.
And I would like to invite you, in fact, to Nepal. We also do the annual conference of Nepal Society of Nephrology. So I hope we will continue to interact in future also.
Thank you. Thank you. Madam.
Yeah, thank you, sir. It's a wonderful program. So one of your slide you have shown that you have linked your deceased donor with the KPD program. So what is your strategy of linking? Like, I mean, how do you, try to allocate a deceased donor to this paired
Yeah,
kidney pairs?
our Soto Gujarat has approved this. For example, with the help of linking living and deceased donor, with the help of using two deceased donor kidney, we can generate 3 transplant. And I think this way is already used in many international registry. Yeah. So for example, there is a O group patient, for example, O group patient having incompatible donor. That incompatible living donor of O group patient will donate kidney to the patient who is intended to receive the deceased donor kidney. So all will be in the benefit. That is a strategy. This is approved by our Gujarat Soto. And this is still not, we have not practically performed this transplant because this was approved in COVID, and now we just came out of COVID so that we can do this transplant. Dr. Michael Rees has performed this. Maybe he can show some light. Living in and deceased donor exchange, sir. Yeah.
So in the United States, we began the non-simultaneous extended altruistic donor chains with living altruistic donors. And some of the concern of the American transplant physicians was that we should, if we have somebody who's offering to give a kidney, we should allocate that kidney like we allocated a deceased donor kidney, to be fair about it. But if you do that, then that one kidney only helps one person. It's now been utilized for about 15 years, that we're taking a living donor's kidney and creating a chain of transplants that's increasing the utility that comes from one kidney. As a result, we've now proposed that some deceased donor kidneys could be used to start chains, and instead of helping just one person, they could help many people. The VEC has shown that you can make a non-simultaneous cycle. So if you can trust everybody and we saw that he's been able to perform a 10-way non-simultaneous cycle that begins and ends at the same place. There's more risk if somebody doesn't donate a kidney. And so their strategy was to repair that risk with a deceased donor kidney. But once you can use a deceased donor kidney to repair a broken cycle, you could use a deceased donor kidney to start a chain. And so I think that in a place like India, where living altruistic kidney donation is not allowed, that a deceased donor kidney could be used to start a chain and help more people than just one from a deceased donor kidney.
Okay, one
Yeah,
last question.
For this swap transplants, you are only doing compatible swap, or you are doing ABO incompatible?
No. At present, we are doing only ABO compatible transplant. But that is one of the way we can do ABO incompatible as well. For example, if the baseline ABO titer is in thousands with your incompatible donor, and if it is below like low titer 64 with the swab donor, this will decrease the cost of desensitization and obviously the infectious complication. This is used in Australian program to increase transplant for O group patients.
And I got a question regarding this: how to start the chain with the diseased donor kidney. So in an Indian scenario, all swab transplants are authorization committee cleared. So how do we propose that the clearance is in place and we wait for the diseased kidney to start the chain?
No, this the exchange of living and deceased donor is approved in the Soto, Gujarat.
No, eventually when we have to do it, sir.
Yeah.
Yes, sir. If you have to do it, even if you think it.
Yeah, for example, there are two cadaver donor on the same day. If there is a O group patient with incompatible donor, that living incompatible donor will give to the person who is intended to get the deceased donor. So he will be benefited. Instead of getting deceased donor, he will get living donor, and these O group patients can get the deceased donor O group kidney. So all will be in the win-win situation.
But sir, how are we going to get three recipients with two deceased?
So there will be two deceased donor and one living donor transplant. Na? Any patient, sir. For example, O group patient and non-O donor, he can donate to the topmost person on the deceased donor who is supposed to get deceased donor kidney as per the waiting list. So in this way, we can increase the donor pool.
But then, sir, is it not only possible where there is a large disease donor, like in Gujarat or in South places where the disease donor program is not that robust?
Obviously, the program should exist there. This is not the primary stage that you should start your deceased donor program with the list exchange.